So my talk, again, unrehearsed, but very symbiotic with Hans Hasselbach's talk, is why the myeloproliferative neoplasms, particularly polycythemia vera and myelofibrosis, should be treated with interferon sooner rather than later. And from a historic standpoint, Hans and I have corresponded for at least 15 or 20 years. We both believe these diseases should be treated sooner, long before we had the data to show the reasons why. And it's only recently that the laboratory studies that Professor Hasselbach has shared with us today have been developed, and the clinical studies that we're developing have suggested that these diseases should be treated sooner rather than later. So in the next 20 minutes, I'm going to show you some of the experience we developed here at Weill Cornell and why I and he agree, and I think with some others in Europe, our colleagues in France and Austria and Germany, why these illnesses should be treated sooner rather than later. So first of all, we all are aware now, based particularly on the studies of the Mayo Clinic group in Scottsdale, Ruben Mesa and his colleagues, that MPN patients are highly symptomatic, regardless of the subset. And when we think of patients that are so-called asymptomatic, that fit into many of the prognostic scoring systems that Dr. Schaefer mentioned, in fact, when you ask patients with MPNs some of these questions, they really are characterized by constitutional symptoms of the type that are listed here. And I'm sure Dr. Scherber will mention some of these later on. So we know that the genesis for the early treatment of PV and myelofibrosis are that these are low-grade malignant diseases at the start. As you already heard from Dr. Hasselbach, these diseases can be detected very early in these CHIP tests that are being done more and more often, that even though they are, how do I go back? I'm seeing, Barbara, I'm going forward. I don't know how to go back with this. Can we go back, please? Let's go back to the, no, go back to the third slide, please. Let's see if this does it. Well, that's it. Okay, I think we've got it. So the MPN patients are considered low-grade malignant disease. They're often symptomatic, as I mentioned, and consistent with our oncologic concepts, these patients should be treated sooner, not later, and early versus late stage, and Dr. Hasselbach has gone into that eloquently, as you've just heard. So the initial treatment of PV is one of the things most of us agree with. We know that all patients must be phlebotomized to a target value of men with a hematocrit of under 45% and women under 42%. And Dr. Spivak and I share this thought that there is a gender difference between men and women, and the target value of 45 in women predisposes them to thrombotic events, so that we must remember that if we're dealing with a woman, we want lower hematocrit values than for men. And the basis for this is the fact that this is, I'm not touching this, so it's going on its own. Something mysterious is happening. Thank you. So that the reason for this is that blood is not is not similar to water, and that the higher the hematocrit, as you can see on the bottom line, the higher the hematocrit, the thicker the blood becomes. We refer to that as viscosity. And years ago, an English hematologist, a very well-known pioneer in the field, John Pearson, showed that the higher the hematocrit, the more likely one would have a vascular event. And you can see that the evidence of thrombotic events occurred more rapidly or more frequently when the hematocrit was high. And that has been confirmed in many studies, so that's why we pay such strict attention and lower the blood counts to a hematocrit of 45, and we follow the red count as well for reasons that we won't go into at this moment. So the issue is that after the initial phlebotomy, we must assess the subsequent phlebotomy requirements first, because we believe that the frequency of phlebotomy will also be a criteria for the stage of illness and the kind of risk factors that are involved in determining what a patient's status actually is. So we at Cornell some years ago took 34 patients and looked at their phlebotomy rates during the first year of treatment when we were doing phlebotomy only. And if you divide these patients into quartiles, you'll see that the range, as shown on the bottom row, varied from 1 to 25. The mean and median number per year were 7 and 8. And if you look at the number of average PV patients, the number of phlebotomies they have, that's about typical. But you'll notice also that there's a significant range. There's patients who only require 1 or 2 or 3 a year, and there are some that require as many as 25. So that must be considered in whether or not a patient has mild, moderate, or severe illness. And that has not been done in any of the risk factor groups that we're aware of, and we're actually developing that now at Cornell. So the issue is, how do you treat patients with PV after the initial phlebotomy to the hematocrit values I talked about? You can continue phlebotomy. That's very popular in the United States and in Italy. You can give them hydroxyurea, which unfortunately is the most familiar form of treatment in the United States and in some countries in Europe. You can give them interferon, which we prefer here and in Denmark and France and Germany and in Austria. Or you can use ruxolitinib after hydroxyurea failures, and that's the FDA-approved method for treating patients who are hydroxyurea resistant or intolerant. So the risk assessment is mainly derived from Italian studies, and they have been very active in this field. And as you already heard from Dr. Schaefer and Dr. Hasselbach, there are 2 major risk treatment groups: low risk under 60 years of age, no thrombotic events, and these patients are advised to be treated with phlebotomy and aspirin down to the target hematocrit, and high-risk patients more than 60 years of age with a history of thrombotic events, and they're supposed to be given some form of cytoreductive treatment plus aspirin. As I mentioned, most often in the United States, this is hydroxyurea, unfortunately, and also in Italy, with the attempt to get the hematocrit down to 45%. Now, for many years, Dr. Hasselbach and I, when we first talked about this at an American Society of Hematology meeting over a beer, we said that it doesn't make sense to have a low-risk patient under 60 years of age to develop a thrombotic event, and then he gets a high risk, he becomes high risk, and then you treat them. And no matter who we spoke to, it just didn't seem to make sense except to him and I. But I think the message finally, Hans, is getting across for the evidence that is being developed not only by you, but by others as well. So let's take a look at a low-risk patient. This was published in Blood, which is the premier journal for us in hematology, by one of our distinguished colleagues and friends. It's a 47-year-old dentist, and this was published in How I Prefer to Treat Polycythemia Vera, and you can see he has a very high hemoglobin hematocrit. He has low iron in his blood to begin with, typical of P. Vera, and he needs 13 phlebotomies. So now we know that he had a pretty high phlebotomy requirement, and he needs 6 phlebotomies a year. That's about average based upon our data. And look, he complains of increasing weakness that limits his activities ascribed to severe iron deficiency. That's our way of thinking. That's not treating a patient adequately, because his sense of well-being is certainly impaired. He can't function well, certainly professionally, and I'm sure his social life and his other activities are limited because of this anemia. So for years, there's been problems with phlebotomy only, and we can't understand why it has become an acceptable form of treatment. And it was first pointed out by almost 30 or 40 years ago by Nagin, who was a very well-known French hematologist, that phlebotomy only was an unacceptable form of treatment in PV because of poor clinical tolerance, frequency of vascular complications. Now you understand the basis of this from Dr. Hasselbach's talk, and the risk of early progression of myelofibrosis because the disease is unfettered and the disease progresses because there's no definitive treatment. And now we know, and then there have been clinical trials demonstrating all of these and clinical reports that related to anemia, iron deficiency anemia. There are more frequent falls, there's impairment in thinking, there's dementia associated with poor exercise tolerance, obviously, impaired tolerance to chemotherapy of one form or another, and impaired results after patients have myocardial infarction. And in fact, there is refractory cardiac failure in patients who have prolonged iron deficiency anemia. So the cardiac literature is filled with the hazards of long-standing iron deficiency anemia. So one of the other things we often see is these physical findings that tell us that patients have iron deficiency anemia, known as chylonychia. I just show you this because a patient came in and said, "Do you think I got this from my husband?" And I said, no, this is because you're lacking iron and you've had too many phlebotomies. And of course, fortunately, the nail findings can revert once the patient has corrected the severe iron deficiency anemia. So the other thing that's really of great interest is the annual rate of thrombosis in the general population. You've heard about the increased incidence of JAK2 that's undiscovered nowadays. If you look at the general population without risk factors, it's 0.6% patients per year per 100,000 patients. In the general population with risk factors, it's up by about 30%. But even in PV patients with low risk categories that we discussed, that is under 60 and no thrombotic events, they subsequently have an annual rate of thrombosis that is almost 4 times the normal population, and certainly 3 times the population rate to begin with. And if you have a high-risk patient, that goes up significantly. It's now almost 5 times the normal population, and 3 times those people with risk factors, and of course significantly increase over patients with low risk. So why would anyone want to allow low-risk patients not to be treated or to be treated with phlebotomy is something that I simply can't understand from a clinical point of view. And it's of interest that this data comes from Professor Barboui, who a colleague of ours, who is a great believer in the use of phlebotomy for the treatment of low-risk patients. So it is well recognized because of this historic data, and it's very often in medicine that facts get forgotten. But again, 30 years ago, myelosuppression was an important component of PV treatment by the Polycythemia Vera study group. That was a cooperative group. You've heard these study groups that Dr. Schaefer mentioned in his presentation. This was a study group supported by the National Institutes of Health. It's no longer in existence, but it was for about 25 years and collected a great deal of data. And the importance of suppression was to control the peripheral counts, to diminish symptomatic splenomegaly, to reduce pruritus, itching of the skin. And as an adjunct to phlebotomy, at that time, the significance of the rate of phlebotomy wasn't really appreciated as it is today. And the drug that was finally selected was hydroxyurea, because at that time, it was the least leukemogenic drug available. Other drugs had caused leukemia at a much, much higher rate. So in a comparative incidence study of thrombosis conducted by this group, after 7 years, you can see that with phlebotomy only in the lower row of 134 patients, 51 developed thrombotic events, a rate of 38%. That could be reduced by Hydrea, but nevertheless, nearly 15% of patients still had thrombosis, indicating that Hydrea was not a perfect drug by far. And these were not contemporaneous studies as well, but it did indicate that suppressing the bone marrow could reduce phlebotomy rate and prevent the thrombotic events. But Hydrea also had toxicity, particularly mucocutaneous forms of ulceration, the worst being on the ankles. It is leukemogenic over a long period of use in our experience and in the French experience, and it takes time for this event to occur. Usually by the 15th year, approximately 10 to 15% of patients have developed secondary acute leukemia. So the specific activities of interferon alpha of interest in PV that attracted us are listed here, and Dr. Hasselbach has already mentioned this. Basically, interferon affects biologic properties involving growth and differentiation and signaling and interactions with other cells, and they're listed underneath in smaller letters. They affect megakaryocytes, those cells that make platelets. It affects red cells and white cells. It also affects capillary and other vascular integrity. It affects the PV stem cell, which is very important, as Dr. Hasselbach mentioned, because interferon will exhaust stem cells in the marrow, leading to their potential cure and then vaccine therapy. And it's, of course, not leukemogenic and safe to use in pregnancy. So the basic rules that we espouse is to start with a very low dose, and the problems with interferon relates to the fact that it was used first in melanoma at enormous doses, 20 million units 3 times a week, and patients stayed in bed because they couldn't live with those doses. And then they used much higher doses in treatment in hepatitis, and then we use much higher doses also in treating chronic myeloid leukemia at 10 times the doses that are used in PV. So we increase the dose slowly. It takes time for these events to occur, for remission to develop, and the important point we wanted to use is to make a patient phlebotomy-free, because that's where the complications occur, in our opinion, because that's associated with the development of myelofibrosis and vascular events. The focus on the spleen is something that we think has been long overdone in modern times, and in fact, in the PVSG, they never paid attention to the spleen size as a criteria for remission. So in our initial 55 patients using very small doses, these patients had clinical responses as defined by the PVSG. They had no thrombohemorrhagic episodes, and as of interest, they were these patients were treated with Hydrea in 30% of cases, and they had very good responses, notwithstanding. There are limitations of interferon therapy. It is an immunotherapeutic agent, as you've heard now several times, and of course, patients complain of headache, myalgia, because it joint pain, because it's the kind of substance that is developed in the body in response to a viral infection, thus the name interferon. But with low dose and with appropriate antipyretic therapy, we believe that most patients, and I think a lot of folks here in this room will testify, normal life can be conducted both professionally and socially. The dropout rate you heard was as high as 40%. In our hands, we've just looked at this. It's about 17% over 350 patients that we've now studied. And it's of interest that although the criteria for discontinuing interferon is obviously different than Hydrea, it's about the same rate as hydroxyurea. Now, everybody asks, how does interferon compare to hydroxyurea? And you heard Dr. Schaefer mention the studies that were reported at ASH. In the bottom curve are patients treated with interferon. This is a study reported by Professor Gislinger from Austria. And on the top line are the patients treated with hydroxyurea. And you can see there's initially a better response, faster as you would expect from hydroxyurea, but by a year to two, the lines cross. And when you look at complete hematologic response compared to of hydroxyurea compared to interferon, you'll notice that the interferon is superior, and that's true for JAK2 allele burden and other parameters that were evaluated in this study. Now, most importantly, we noticed, because we're very keen on bone marrow biopsy, because this is a marrow disease, and examining the biopsy of our patients regularly, as many of you folks from Cornell who are patients here know. And we found that we could pick up early fibrosis in the bone marrow. And here you see a fibrotic marrow in a patient who is otherwise basically asymptomatic. And that big cell in the middle, that giant cell, is a megakaryocyte. That is the bad guy. That's a cell that we think produces the fibrosis that you subsequently see. And this patient had a lot of fibrosis. We call this reticulin. You see these heavy, dense lines. And after 3 years of treatment with interferon, you can see normal marrow architecture. And this patient had a restitution of normal hematopoiesis, that's growth of red and white cells. But you can see these megakaryocytes, those big guys, one on the left and one on the right, they're still atypical. So we don't think that we're curing the disease, but we think we're putting these patients in a sustained remission. And that's why vaccine therapy may be of great value in early in this kind of phase disease, as Dr. Hasselbach mentioned, because we don't think we're really going to cure these patients, but we think we are having prolonged remission so that we can even discontinue interferon therapy. So we had the opportunity to look at myelofibrosis-free survival in our patients, and the top line is those that received interferon. In the bottom blue and yellow curve are those patients who had received Hydrea or phlebotomy only, and you can see for the first time that now there's been a substantial difference in the development of myelofibrosis by treatment in a retrospective study. And this was done with our colleagues, Dr. Abuzena and our statistician, Spencer Krzyzewski. So how about early myelofibrosis? Well, this led us to consider the fact that we were treating primary myelofibrosis in late-stage disease, not consistent with the concepts that Dr. Hasselbach and I espouse primarily. And so we decided that we would treat patients who had bona fide primary myelofibrosis and secondary myelofibrosis early using accepted World Health Organization criteria. And Dr. Schaefer mentioned some of these risk categories, which we can define as early, intermediate, or late. And we wanted to start treating early, not late. And so we selected early and intermediate phase patients based upon these risk categories, which you've heard in his talk and which I'm not going to repeat now. So again, you can rank by standard accepted criteria, and that's why we have these categories in these meetings, so we agree on what is a complete or partial response, a clinical improvement, et cetera. And then we used, again, very low dose therapy, and we had the usual exclusions to interferon therapy, which I mentioned already in my talk in the patients with polycythemia. And the net results was of 30 patients, and it took long to get these effects. We had, as defined, by the World Health Organization and others, 2 complete responses, 9 partial responses, 4 patients with clinical improvement, 7 had stable disease, and there were no responses in 6. So that of the 30 patients, about 70% had stable disease or better. And of course, everybody says immediately, well, this is a single-arm study, and you didn't have any controls, and that's absolutely true. It's our intuitive feeling that those patients would have progressed because that's the natural history of the disease, and it was this experience with these 30 patients were far different than our experience with others who didn't get this form of treatment. But obviously, it needs a complete randomized trial. So everybody focuses on this JAK2 allele burden, and we think that's oversold. It's not similar to looking at the molecular abnormalities in other diseases, particularly chronic myeloid leukemia, but we did see a decrease of around 25%, but it wasn't really correlated with anything, either clinical response to fibrosis or spleen size. So there's lots of other abnormalities that you have to consider in addition to the JAK allele burden. We see patients always come in and say, how's my JAK level today? And, you know, we don't want to over-focus on that. Although all things being equal, it's probably better if it's going down rather than going up. Now, these results, I think, have been confirmed in part or whole by Dr. Verstovsek and his group in MD Anderson, and also you heard Dr. Kalajian from Paris. Dr. Schaefer mentioned in his talk, and Hans Hasselbach are now trying to improve these results by combining the drugs with ruxolitinib. So the basis for early treatment with interferon is you want to, as you've heard, treat when the cancer clone is small, when the minimum tumor burden is preferentially sensitive to interferon. This is entirely consistent with his concept, and as I said, we didn't rehearse this beforehand. And to activate those residual stem cells when the compartment is relatively small, and then you preferentially deplete the malignant clone. This is concepts of ours and first published really by Ann Mullally in Boston, but very similar to those of us who are also interested in chronic myeloid leukemia, and that's the basis for the success and cure of that disease. So the treatment implications is we believe early treatment is successful to watch for waiting. It avoids the development of thrombosis and advancing of primary myelofibrosis and secondary myelofibrosis. It's consistent with the general concept of treating cancer with minimal tumor burden, and early treatment with interferon may target both the malignant clone and the chronic inflammatory state in the MPNs, which you've heard about. So I think if you look upon the MPNs as a big rock to climb, we're about 3/4 of the way there with interferon and Rux and imatinib and transplantation and other treatments coming down the line. We have a little ways to go, but maybe in 20 years when you guys come back here for another patient symposium, we'll be at the top of the crest. So I want to acknowledge all of our group, and I thank you for your attention. So here is our group. I see. This is again not rehearsed, but they're all wearing dark clothes, and I'm wearing a white coat. So you know who's who. Thank you. I think, Mr. Bowie, there is a break now. I'll ask. Are there any questions from my? I can tell you that. Any questions from our co-speakers? Dr. Schaefer, Hasselbach, Verstovsek. All right, thank you. Well, there's a break now for coffee. Thank you for your attention, and we convene at 11 o'clock. Please ask Dr. Schaefer, Dr. Hasselbach, myself questions. That's the reason for this conference.